Good morning and welcome to this MedIQ Facebook Live event entitled Clinical and Legal Perspectives of Telemedicine. My name is Mark Hakam and I'm Director of Risk Management and Patient Safety here at MedIQ. You know, we've really seen telemedicine making a positive contribution during the COVID-19 pandemic, and we're seeing it being used in a variety of ways. But telehealth does have certain limitations, and it can, in some situations, create liability risks that physicians may not be aware of. Today, I'm joined by Dr. Elizabeth Wiley, a family and preventative medicine physician in Washington State. Dr. Wiley has several years' experience treating patients virtually. We're also joined by Jake Kocienda, a trial attorney with the Connecticut-based law firm of DanaherLagnese. Jake has extensive experience in the areas of medical and professional liability. Thank you both for joining us today. Our goal this morning is to gain some perspective on what it's like to practice virtual medicine and also review some of the legal issues clinicians should consider to decrease their liability risks. For those of you joining us live, we encourage you to post comments and send along questions, and we'll do our best to answer those near the end of the program. So Dr. Wiley, tell us a little bit about what it's like to be practicing telemedicine.
Thanks, Mark. Well, it's certainly a very exciting time for telemedicine and for virtual care. As you mentioned, I've been sort of practicing virtual care really predominantly for the last couple of years, and have seen the power of virtual medicine to really help advance the quadruple aim. But we seem to sort of be in a new era of telemedicine, of virtual care. I do think it's important just to start with a bit of a definition. I think video visits and video encounters with patients have really gotten all of the attention at the moment, and have been a source of focus. But I do think it's important to acknowledge the full spectrum of virtual care, which includes, even something as simple as telephone encounters, but also, chat and messaging services, whether synchronous, asynchronous, patient portal interactions, as well as sort of all components of virtual care, and all really opportunities in the current pandemic. So I think I just wanted to start by highlighting sort of 5 observations of some of the changes that I've seen in virtual care delivery in the last month, as the COVID pandemic has emerged. And I think the first is quite obvious. It's that increase in volume, the really exponential increase in volume in virtual care. I speak from a sort of outpatient or community-based setting. So primary care and urgent care are sort of the predominant forms of care that I practice, whether virtual or face-to-face. And, I've really seen virtual care in those settings go from a novel sort of option, and something that we offer patients, to being sort of the preferred modality for care delivery, and in less than a month. And in a lot of ways, that is so exciting to see. But of course, as you mentioned, that does raise the sort of, create some potential risks. Certainly want to acknowledge that a lot of these changes have been supported by, CMS's initiatives to increase access for Medicare telemedicine services, as well as HHS, Office of Civil Rights, sort of exercising that enforcement discretion, and waiving penalties for healthcare providers who serve patients, in good faith, through platforms, whether or not they, comply with existing sort of HIPAA requirements. Although of note, social media, I think, is still off the table, and specifically Facebook, TikTok, Twitter, those types of avenues for care delivery, which is, appropriate, of course. I think that the increase in volume, though, has come, at a time where some practices and systems and institutions may not have been fully equipped, both from a technological perspective, but also from a training and support perspective. And so I think that's certainly created a lot of stressors and needs to sort of create new workflows, realign members of the team. And I think another sort of group that has, experienced a lot of uncertainty related to that virtual transition are learners. The other side of things, of course, is the digital divide for patients. Access to adequate technology is not universal, and patients' comfort levels with technology. I have been very impressed and quite surprised at how many patients do sort of embrace and adapt to technology, but there are a lot of vulnerable populations for whom, technology and video visits and virtual care are not accessible. And so those, aspects of the increase in virtual care are important to keep in mind. The second sort of major observation is once again pretty obvious, but it's the increase in scope and really pushing the boundaries of conditions that are managed remotely. And I'd say personally, I've certainly felt this, very acutely as we saw Washington State start as sort of the hot spot for COVID, and really, having to manage a higher acuity of symptoms in the patients and assessing patients without sort of those vital signs or, the benefit of a physical exam is uncomfortable, even for those of us who are relatively seasoned and who have been practicing, virtual medicine for a while. There are, of course, many resources available. There's a great BMJ infographic about telemedicine management of COVID, specifically in primary care settings. And but at the same time, it is challenging. You don't know what the pulse ox, of a patient you're talking to via video
Right.
is, and how to advise them. Similarly, I think that there's also, within this sort of scope, I've never had as much trouble convincing patients to go in for a, physical exam as I have in the last few weeks. And most frequently, those situations occur around, non-COVID related complaints. I mean, there obviously are still, plenty of other conditions that emerge and need to be treated. And that I think is an important discussion and conversation. And I'll talk about documentation as well in just a moment. The third sort of change or observation I would put out there is the sort of uncertainty and the limited evidence and constant change that providers and patients are dealing with. And that's a challenge whether you're providing face-to-face care or virtual care. But I spend at least 15 to 30 minutes each morning just trying to read updates and trying to sort of stay on top of a lot of the new developments, whether it's testing criteria or, COVID implications for pregnancy, reinfection, hydroxychloroquine and azithromycin as treatment, ACEs and ARBs, NSAIDs, all those types of issues are, huge and areas where we don't have a lot of evidence. And when you compound that with the uncertainty of not having, the physical exam, the vital signs and that sort of information, it certainly creates a much a challenging and like I said, uncomfortable environment sometimes in which to provide advice or care to patients. The fourth area or observation I would say is just that, virtual and patient encounters, much like face-to-face encounters, can be challenging. And I think that currently that's very much exacerbated by the stress and anxiety that a lot of the changes in the way that we function have been implemented in the last few weeks. Seen quite a bit of anxiety associated with isolation, fear, social distancing, socioeconomic factors, and uncertainty of employment. And then, a perceived powerlessness when it comes to access to testing or, unproven treatments, those types of things. And, managing angry and frustrated patients can be very stressful and demoralizing for us as providers. And I think that that's the case, in the virtual environment as well. Certainly I've experienced that. And so, navigating, those types of situations is I think oftentimes just, like I said, challenging and de-escalation techniques really can be helpful. And I think, need to be adapted to the virtual setting. And we can, talk a bit more about that. But, especially when there's a sort of technology mediated encounter, ensuring that you're conveying empathy and acknowledging sort of patients' concerns is important, and I think can sometimes get sort of left out. The last area of observation I'll sort of put out there is just documentation. Very much a less sexy topic, but is very important. And I've seen in particular for providers who are, transitioning to a virtual environment rapidly and who, may be overwhelmed with the volume of virtual care that they're provided, that there is that temptation not to document, that virtual care and virtual encounters are not, don't require the same level of documentation as face-to-face encounters. And I think that that's a real mistake. I mean, both from a patient safety perspective in terms of, integrating, care, but also from a risk management perspective. And so just wanted to highlight, the importance of documentation, in
patient
the
interaction is that whether it's virtual or real, it's still has to be documented.
Absolutely.
Great.
Yes, and so look forward very much to the discussion and questions.
Great. I'm gonna pass along a question, Dr. Wiley, just for you to see if you can think about, not expecting you to answer it in detail, but somebody has asked, what are the current updates for risk of COVID exposure in pregnancy? And perhaps you maybe can direct this individual in that direction. We really don't have time today to go into clinical specifics of that, but maybe we can help this individual as to where they can find that information. I do want to shift over and give Jake a chance now. Jake, what are some of the risks that physicians need to be aware of when dealing or making the decision to treat patients virtually?
Well, thank you, Mark, and I appreciate everyone who's attending the broadcast. There are a lot of risks. Of course, there's the usual risks and the things that need to be always considered through regular clinical practice. But the telemedicine and the technology that's involved and all the limitations that technology of a virtual visit entails should be kept in mind. One is that, to start with, is the billing. Frankly, the billing is one issue because there are a lot of codes now that actually take into consideration the telemedicine. Mental health field has a lot of that. And some pitfalls can arise, and you have to be careful of those to make sure that you're very accurate with how you're billing and where that billing is being considered within the context of all the care. So some greater attention and getting accuracy in those codes and how it's billed is important. There's a lot of other limitations, though, that should be considered as well. So there's the clinical, and just the simple idea that you're now virtual. You don't have a lot of the very simple tools that a clinician would have in a face-to-face, in-person environment. There's no physical exam, which seems obvious, and yet that is such an integral part of what's done on a day-to-day basis with office-based practice and hospital encounters, that when that's taken out of the equation, if you're not prepared and you don't think that through and you're not experienced and expecting it, you may lose that additional piece of information, and then you have to make decisions. Standards of care still apply, generally speaking, and you have to know the laws and in particular, any statutes and particularities to your jurisdiction. But generally speaking, the standard of care is based on what a reasonable physician should do under all the relevant circumstances. And you can see from a telemedicine standpoint, the circumstances, many details of those have shifted dramatically. So what you can do in an office setting and what the standard of care would require in a telemedicine setting can be very different, and you need to be conscious of those before making final decisions. There's the technical limitations. Frankly, a poor connection, inadequate audio, relying on visual things that you're looking at. Your connection may be very good, and yet the patient's and what you're seeing from the patient's standpoint and your screen could be very poor. That could limit things in that particular encounter that may not be present or something to concern about in other encounters. Dropping feeds, not being able to make appointments, mid-conversation of telling someone something very important and then the conversation drops because of the technical. What do you do and follow up with that? These are things that should be thought of well in advance with a plan in place in your mind, whether it be your organization, facility, or just in that particular encounter, so that you can act on those and not wonder what to do. There's also the confidentiality issue. There's video. Who's around you? Who's around the patient? Who can see? And sort of a subcategory of that is recording. You can record what we're doing today. You can record almost every video and audio encounter. The laws in every jurisdiction as to whether you can do that without knowledge of the other person differs greatly. And more importantly, you may never know what's being recorded. So the encounter may be recorded by the patient and you may not be privy to that. They may not know they have to inform you of that. There's the informed consent of the very nature of the telemedicine encounter. Putting aside the informed consent aspect of any clinical encounter, procedure, or care, you also have the patient's expectations and understanding and appreciation of all these limitations. They have to be well informed, and if they're not well informed, they may agree to such a telemedicine encounter, and in the end, have no understanding or misunderstanding of the limitations and would never have agreed to something or claim they've never agreed to something had they been well aware of those technical limitations, the clinical limitations, and things of that nature. So a robust information packet signing off details to the patient need to be well established and understood before that encounter occurs. There's also the documentation, which Dr. Wiley mentioned, and frankly, documentation becomes even more paramount in this setting, because assuming there's no actual recording of what's going on, your documentation of everything is going to be highly suspect and highly critical and scrutinized if there's ever to be a challenge to the care and the outcome of whatever that outpatient procedure and encounter was. So your documentation should be more robust and more detailed oriented than ever before, with details and clarity to be sure before you sign off on a note. And then also the last limitation I want to mention, although there are others, is when to end the encounter and send that patient to the next level of care. That threshold is no longer the same as it would necessarily be in an in-person encounter. And the human nature of attempting to say, well, let me just do something for this patient now, can be sometimes overwhelming. The threshold of when to end that conversation and send the patient to the ED, to an office visit, to a higher level or a different specialty, that threshold should be really considered and understood before you complete or before you begin an encounter, and make sure you're following it and document well when you don't send someone to another level of care or when you feel the need to. And make sure that communication is clear to the patient. There's nothing that can be signed. You can't give an informed consent to sign it necessarily. You can do it virtually, but that's not necessarily the same. And of course, the resources available to that patient are going to be different from patient to patient. Telemedicine allows you to take care of patients 15, 20, 30, 40 miles away from a hospital. So they may not be able to go somewhere, but you need to know that about your patient and what limitations and resources are available to them in making decisions. So keep some of these decisions and these limitations in mind when practicing, and think about them before engaging in the telemedicine so that you don't have to think about them on the fly in the middle of an encounter, which could delay sometimes very serious time limitations and put your patient in jeopardy.
Great. Thanks, Jake. Boy, we've had a lot of questions come in. So let's go, let's start addressing some of these. We're going to go back to Dr. Wiley and talk about the pregnancy and COVID. Where can somebody find the latest updates on that area of medicine?
Sure. Obviously, this is one of those places where there's limited evidence. And, of course, I think, women who are pregnant are considered at higher risk for complications, but the basis for that designation is not entirely grounded in a lot of data. The CDC website, particularly for patient-facing information, is, I think, a great place to start. I know there are some institutions or health systems that also have put out information. So I would, recommend checking to see if your institution or health system has put out any, any particular messaging around this. But I think the bottom line is this is one of those places where there's tremendous uncertainty in terms of the effects on pregnancy.
Great, thanks. Question for Jake. Telehealth care is provided by a physician located in one state with caps on malpractice awards. Patient is in a neighboring state that doesn't have caps. Medical malpractice claim is brought against the physician in the patient's venue. Will the physician's med mal insurance cover the physician for a claim made in the no cap state?
Well, I'll be straight up. I can't answer that question because every policy is going to be different. But that question raises one limitation and another thing that's extremely important. And perhaps I should have mentioned this before you get involved in telemedicine. You need to be sure your malpractice carrier is aware of it, that you've disclosed it, and be sure that you're covered for whatever it is you're going to do. Practicing and taking care of a patient through telemedicine in different jurisdictions across state lines may not even be allowed within your state. So you may be violating a law in that context alone, and certainly your licensing within the state. And then you want to make sure that your insurance company is aware of what's going on so that if there are special riders or additional coverage you need, you can have that in place before you begin. So to answer your question, I have to direct you to your carrier and to the laws of your particular state and know what those limitations are. They're not universal. They're not global to the entire nation. And so with that specificity, you definitely need to find those answers before you begin practicing telemedicine.
Great, thank you. Here's a question, an interesting one. We have a chaperone policy to ensure patient safety when seen in the office. How do we do that with video telehealth?
I can jump in on this one, I suppose.
Go ahead.
But I assume that the question probably pertains to sensitive exams more than anything else. And, I would say personally, and, in the environments I work, there's sort of a policy. There's no, I don't conduct sensitive exams via video for precisely that reason. I mean, because, face-to-face, it is universally a sort of opt-out chaperone type of situation. And so, would never want to make a patient feel uncomfortable in asking or requesting to do that exam. Of course, I will say sometimes patients will simply undress. And that is awkward. But in general, those are the types of exams that I defer to face-to-face.
Great. And I would guess that's something you would want in that informed consent document at the beginning, right?
Yeah, actually,
yes.
I'm sorry, Dr. White. Yeah, that will be something I would definitely expect to be included and understand in those limitations before both manage patient expectations, but also understand the clinical limitations in examination and get that straight from the beginning.
Manage those expectations on the front end. There won't be a chaperone present. We're not going to be doing intimate exams. We're only going to be doing A, B, and C, not X, Y, Z.
Absolutely.
All right. Another question. Thought on issuing certain devices to patients so they can monitor at home and report results virtually, such as a blood pressure cuff, Doppler, etc. Do you have patients sign some sort of agreement before taking such devices home? I'm going to field that one to Dr. Wiley. Any experience with that?
So I work in an environment, in a system where that's done independent of me as a physician practicing. That's done by sort of institutionally and is sort of standardized. Certainly, if you were sort of initiating a program like that, I think it would be important to sort of lay out those parameters prior to sort of starting.
Great, thank you. Here's another one. Question. Advice about finding opportunities to work in telemedicine during this crisis. I'm immunocompromised, so face-to-face care isn't practical for me at this time, but I still want to provide care. I would guess contacting local hospital systems as a possible start. Any other thoughts there, Dr. Wiley?
Absolutely. I mean, I just certainly don't want to endorse any particular health system or service, but there are a wealth of different, institutions or organizations who offer those types of opportunities that I think are at this point sort of actively soliciting providers, whether physicians or otherwise, in this time, and when virtual medicine is becoming so predominant. But I obviously encourage using sort of typical channels, but there certainly is a need in a lot of places.
Great. Here's a question. If I were to do telemedicine and I'm in one state and my patient is in another state, do I have to be licensed in that state? Jake, what are your thoughts on that? On the state where the patient is located?
Yeah, generally speaking, first of all, it's a good idea just generally, but generally speaking, that would be the licensing and the regulatory and the laws that almost every state would require. Certainly check with your state and find that out, and the state of where your expected patient is. But the general answer is yes, you should be licensed in whatever state you're practicing medicine. It's not only a good idea and protective, but the state of the patient very well may consider you practicing without a license in that state. that can essentially cause a lot of problems, both in the clinical, the licensing, as well as billing and other types of regulations in the federal and state government.
Okay.
So yes.
What are your comfort levels of doing telehealth for well-child visits, specifically well-child visits for those very young kids? We want to keep them out of the clinic, yet these visits typically have a large physical exam component. My providers are worried about missing some things due to not having that physical exam, yet I wonder if some type of visit is better than no visit at all.
That's a great question, and I think that that is, another example of where I think a lot of us are sort of learning on the fly, and there's not necessarily evidence, at this point, because it's not something that has really been done to any significant degree previously. I think it very much depends on sort of the nature of the which well-child visit we're talking about. I mean, I think another very important question is immunizations that are often associated with those well-child visits. And so, obviously ensuring that patients are maintaining the recommended immunization schedule and getting those physical exams in can be important. I think that some of those visits may be exceptions, and of course there needs to be precautions in the face-to-face visits, as much as possible, to avoid the risk of transmission. But I think that this is exactly what we mean in terms of sort of those new and sort of uncertain areas of practice.
Great, thank you. What recommendations do you have regarding the actual consenting procedure? Our organization is requiring a statement of consent from the patient before we start talking about their problems. So the clinician would make a statement highlighting the risks and benefits, and the patient would state that they consent. Do they need to do they need to have these witnessed? Do they need to sign something? I don't see that CMS is requiring anything beyond a simple statement of consent. Any thoughts?
From a risk mitigation standpoint, I think first off, any type of telemedicine plan and expectation with the patient should start with the patient actually being seen and physically in the office, and start that relationship that way. That may not be possible in all cases, but certainly that allows for that back and forth interaction. And the informed consent part needs to be very, very robust. It's one thing to have informed consent for medical issues where the doctor's of knowledge and there's an expectation that the physician or the clinician is going to relay the information, and then the patient will make a decision. In this context, there's an integration of both the technology limitations, all that the dynamic of the communication entails, plus how it interacts and affects the clinical in a way that is unique. It has not been well fleshed out in many cases. It's a new burgeoning way of doing medicine. And so it needs to be very robust. I would definitely recommend, and none of this is absolute, but for risk mitigation and to protect yourself, have that initial conversation, informed consent in person so that it's clear. Have lots of information, documentation, so that the patient can take it home, have it, and be able to refer to it when and before additional telepractice events occur. And then, of course, make sure that it's understood that things change and the dynamic can change within any given encounter. So nothing is absolute, and the patient needs to understand that. Have them sign off. I would have them witness just like any other informed consent if you can. But keep in mind, informed consent discussions and the documentation are not necessarily the most important part. It's the understanding of that patient and making sure that they understand what it is you're talking about. And that could very well depend and be influenced by the level of technology savvy of that patient. Some may absolutely understand and maybe even have more thoughts than you would. And then others, as mentioned by Dr. Wiley, may not even really know how to turn their computer on, and yet they're doing this. So patient by patient, that is really important to understand their limitations and what they understand. Start with an inpatient meeting and go from there.
Great. One final question. We're coming up to the end of our time. Some quick comments from both of you. Any recommendations, clinical or medical legal, regarding telemedicine and psychiatry in particular? Just many states are waiving their licensing requirements currently. Final thoughts from either of you?
Sure. Mental health telemedicine is getting more and more involved in this for lots of reasons. Very quick, just to keep in mind that because you don't have a patient in front of you and you are trying to assess what's going on, there are requirements that patients do still need to be seen in person. I know there's been a relaxation of standards, as I mentioned before. Circumstances define the standard of care and generalities. There's also relaxing of the HIPAA requirements in some degree. But for mental health, it's very important that the patients understand those limitations and you're very cognizant of what can and can't be done while you're not personally with that person. It's very easy to click a button and end that conversation. It's a lot more difficult to stand up and walk out of a room. So you want to make sure you have a good understanding and the patient has an understanding of what's going on, what to expect, and you have some type of game plan should something be going south and you may need to take more action, like getting a second or a higher level of care involved.
Great. Dr. Wiley, any closing comments on that question?
I don't know that I have anything specifically to add that's psychiatry and unique, other than of course mental health and psychiatry are so important right now, and so it's great to see the expansion of virtual health to include psychiatry and mental health.
Great, thank you. Well, that's all the time we have today. We encourage our followers to take a look at MedIQ on the various social media platforms we have: Facebook, Twitter, LinkedIn, Instagram, to hear about all the clinical risk management and patient education we have to offer in a variety of formats. We'll have more information coming out about COVID-19 and telemedicine. Thanks for joining us. Wash your hands and have a great day.